So welcome all to the next guideline, the prevention of malaria in pregnancy. We begin with our quote, master MRCG with concept-oriented clarity. So this particular guideline will discuss about this is an evidence-based guidance on malaria prevention in pregnancy for UK residents. Okay, so this guideline will cover about women who are planning the pregnancy, pregnant women, breastfeeding women, and drug prophylaxis which are recommended that may change depending upon the resistance in that particular area. Okay, malaria is a preventable, but it's a life-threatening. It is caused by the female Anopheles mosquito. What was the mosquito for the Zika?
Aedes aegypti.
Yeah, female. Okay, and activity, which time the Aedes is active?
Daytime, late afternoon till dusk.
Correct. And this female Anopheles is mainly in the night time.
Night time.
So basically, again here, this is an imported disease. Okay, there also Zika we saw, and most of the scenarios will mention that there is a history of travel. Then think of the region where there was a travel. Think of the endemicity of that particular area, which infection is endemic, and look for the clinical features, and then select the option. Okay, so these UK imported cases mainly were Plasmodium falciparum in 79% of cases. This was the most dangerous and most deaths, mainly West Africa, especially Nigeria. And the reason is that even when they visit, the chemoprophylaxis is suggested. In Zika, there was no chemoprophylaxis. Here, there is a chemoprophylaxis. But most of the patients, they have mentioned here in further that low uptake of chemoprophylaxis was there. Okay. In Plasmodium vivax, there were 13% cases, and mainly this was found in Asia and Indian subcontinent. And it is one of the important feature about vivax is relapsing malaria. Even oval, it is relapsing. Okay, so there can be recurrence even up to 1 year or maybe after that also. So there may be initial infection, but there can be relapse also. Okay. In Plasmodium malaria, 2% late recurrence after years, especially this malaria. The cases are less, but less recrudescence, late recrudescence after years is also known to happen. So these are actually the species, and this is the most dangerous. Okay, and most common in these areas. This is common in Asia and Indian subcontinent, but this is a relapsing malaria. Okay, then rare Plasmodium novesi from Brunei and mixed infections. High risk group are UK travels, visiting friends or relatives in West Africa. And there is a low uptake of chemoprophylaxis. Pregnant women rarely reported in UK malaria data. Okay. Now coming to the medical complications of malaria in pregnancy. It's a high-risk pregnancy due to low pre-immunization. That means natural immunity is low because these patients are not exposed to this particular kind of, these UK residents are not exposed to this infection more frequently. So natural immunity is very much less in these patients. And that is why severity is more. Okay, if there is some kind of natural immunity, especially what happens in the endemic area, they have got a high premonition. Okay, high premonition is there, so they have got a less severity of the disease. Okay, now consequences: maternal mortality and pregnancy loss, such as miscarriage, stillbirth, preterm birth, low birth weight, long-term health issues. Then there can be severe anemia secondary to malaria. Okay, then cerebral malaria, placental parasitemia can be there. Pregnant women in endemic areas are twice as likely to be bitten by Anopheles mosquitoes. Increased risk of contracting and dying from malaria compared to non-pregnant women. And clinical outcome depends on degree of premonition. We will see in the subsequent slide. If there is a prior exposure or immunity, then the severity will be less. And UK-based travelers are highly susceptible, and this is mainly because they have got a low premonition. Okay. So this is what is the severity of premonition in the UK. They have got a high severity of the disease because of low premonition. So susceptibility to infection is high, risk of illness is high, severe anemia status is not known. But where those patients who are from endemic region, they have got a severe anemia which is more. Okay. Then cerebral malaria can happen in these low immunity patients. Then here maternal fetal mortality is high because of the low immunity. Low birth weight status is not known, but other obstetric complications such as miscarriage, preterm birth, stillbirth, they are high. So if you see here, severe anemia is common with a high immunity in the endemic people or those people who stay in the endemic area, while obstetric complications are high in patients who are having low immunity. Okay. Then all gravidas are at risk. Here mainly the primary gravidas are at risk. And placental parasitemia is not known, but it is known to happen with this particular thing. Okay. So what will be the travel advice for pregnant women who are for prevention of malaria? If travel to endemic areas is unavoidable, then seek expert guidance, consult malaria prevention specialists before travel, and be alert for symptoms, fever or flu-like illness during travel or up to 1 year after the travel. Always seek urgent medical attention and carry out the fever profile, including the malaria investigations. Okay, so even if there is a history of travel, 6 months or 8 months in the scenario, think of malaria also. Okay. Understand the risk at destination. This we have seen with Zika also. Consider transmission, season, rural urban stay, drug resistance, and travel duration. High risk will be visiting friends and relatives in the West Africa like Nigeria, Ghana, Uganda. And low risk are the urban Southeast Asia, Bangkok, Phuket, etc. Okay. Then ABCD of malaria prevention. Okay. Now, what is ABCD? A is awareness of malaria risk at destination. So we should know what is the malaria risk at destination. B, bite prevention, that is repellents, nets, protective clothing, etc. C stands for chemoprophylaxis or the anti-malarials. And D stands for diagnosis and treatment, prompt medical attention if symptoms appear. Now, these are the countries of travel, and this is what is the risk. Okay, risk of contracting malaria during 1 month stay without chemo. So, if a UK resident travels to these countries, what with and stays for 1 month without chemoprophylaxis, what is the risk? So, if there is a travel to Oceania or Papua New Guinea or Papua or Solomon Island, so then there is a risk of acquiring malaria is 1 in 20. Sub-Saharan Africa, it is 1 in 50. Indian subcontinent and Southeast Asia, it is 1 in 500. Okay, South America is less. Okay, Central America is the list, 1 in 10,000, followed by South America, 1 in 2,000. But these particular countries are very high. Up till now, these figures have not been asked, but you still can remember which is the highest one and which is the lowest one. And Asian countries are in the range of 1 is to 500. Then Sub-Saharan Africa. So remember Africa and this 1 in 20 for New Papua Guinea, etc. Okay. Then coming to the bite prevention. Okay, first we saw about the awareness. Now coming to the bite prevention measures. So in insect repellents, apply repellents such as DEET, that is diethyl metatoluamide. The same we have seen with the Zika also. DEET up to 20% is very commonly used, and it has not been found to be harmful to the mother or baby. But up to higher concentration are indicated. Up to 50% you can use higher concentration, and longer duration is recommended. It is safe for pregnancy when used as directed. Okay, so protective clothing is to be used. Sleep under the insecticide treated bed nets. Then stay in well screened or air conditioned accommodation. Avoid outdoor activity at peak mosquito hours. Use indoor insecticides wherever appropriate. Remove or cover standing water, etc. So these are actually the advices. There is no as such direct question, so I'll avoid the further discussions on this slide. Then let's talk about the malaria prophylaxis in pregnancy. Okay, what are the drugs? We have chloroquine, mefloquine, atovaquone, and proguanil, doxycycline, and primaquine. Okay, now out of which doxy and prima contraindicated. Primaquine, they are contraindicated. This doxycycline avoid due to effects on fetal death, fetal teeth and bones, and primaquine causes hemolysis in G6PD deficient fetuses. Okay. So this, and then coming to the most commonly are the chloroquine, mefloquine, and atovaquone plus proguanil. Out of which this chloroquine and mefloquine are safe. For atovaquone, proguanil, there is a limited safety data. Okay, this all also we should know. Mefloquine and chloroquine, they are safer. This has got a, but still, if benefits still outweighs the risk. Okay, and use where the chloroquine, there is no resistance to chloroquine. So chloroquine will be used if there is no resistance. Otherwise, mefloquine will be the always the drug of choice for chloroquine resistant areas. Okay. Then let's see about suggested waiting times before pregnancy and teratogenicity data. Mefloquine estimated half-life is 2 to 3 weeks, and execution time is 3 months. Again, not these are not asked, but in animals they have shown skeletal and muscular malformation in rats. Post-marketing and case reports, no evidence of embryo toxicity. Mefloquine is relatively safe. Doxy, there is a disturbance of the bone growth and congenital cataract. Okay. Then this Atovac one, okay, there is a limited data, but still, when the benefits will outweigh the risk. Progranil, decades of prophylaxis use, no fetal toxicity. Okay, chloroquine, no adverse effects in the first trimester also. Okay, so chloroquine can be used in any treatment. Sometimes if you are given the scenario of first trimester, we may get confused, but chloroquine can be used. Okay. Then coming to the chemoprophylaxis in pregnancy and breastfeeding. So which drug and what should be the dose? So mefloquine, we have seen two drugs, that is mefloquine and chloroquine can be safely used. Then proguanil and atopine can also be used. Okay, while rest other two drugs were contraindicated. Okay, now let's see about mefloquine. The dose is 5 milligram per kg weekly. Okay, this is the drug of choice in second and third trimester for chloroquine resistant areas. Safe in prophylactic doses. There is no increased risk of stillbirth or malformation. Our treatment doses, that is 25 milligram per kg, one study linked to the stillbirth. So this is the treatment dose, and this is the weekly 5 milligram per kg is the prophylactic dose. Can be used in the first trimester if malaria risk is very high. Then contraindications will be depression, neuropsychiatric disorders, epilepsy, hypersensitivity to quinine and mefloquine. Then atovaquine, proguanil. Okay, potentially good candidates second and third trimester, but insufficient safety data may be considered if mefloquine is contraindicated with specialist input. And contraindicated drugs are doxycycline and primequine. Reasons also we have seen. Okay. Now coming to the chloroquine and proguanil. Okay, they are safe but ineffective in resistant areas. Then what is the breastfeeding recommendation? So same recommendation as in pregnancy. Mefloquine is excreted in small amounts in the breast milk, but there is insufficient. So let's see about the breastfeeding is same recommendation as in pregnancy. Mefloquine is excreted in small amounts in the breast milk, but there is insufficient safety data. Atoquine and proguanil may be considered with specialist advice if mefloquine resistant areas. Emergency standby treatment in pregnancy. So what is the emergency standby treatment? So suspected malaria in pregnancy is a medical emergency, needs urgent diagnosis and treatment. So standby treatment only if remote travel without medical access. Okay, written instructions must be provided. Criteria to start is a flu-like illness and any fever more than 38 degree. That will be the emergency standby treatment. So what is the UK recommended treatment? Quinine 300 milligram, 2 tablet TDS for 7 days. So that is the emergency treatment plus clindamycin 150 milligram, 3 capsule TDS for 5 to 7 days. Remember, this is for 7 days and this is for 5 to 7 days. That is what is the recommendation. So quinine plus clindamycin, that is what is the recommended treatment. If there is a vomiting within half an hour, then you have to repeat the full dose. And if the vomiting is after 30 to 60 minutes, repeat half the dose. So this can also be asked as a question. Then they'll mention the duration the patient vomits immediately after. That means within 30 minutes, you will have to repeat full dose. The drug of choice will be quinine plus clindamycin. Okay. And if she vomits after 30 to 60 minutes, you will have to repeat half dose. Okay. Complete full course, restart mefloquine prophylaxis 1 week after finishing. Okay. So this will be the standby treatment, followed by the chemoprophylaxis, which was weekly 5 milligram per kg mefloquine. We have seen the drugs which are used for prophylaxis. Okay. Alternative regimen will be atovaquine plus proguanil and Riamet. So these are the alternatives to quinine and clindamycin. Now dosing regimen for chemoprophylaxis, this mefloquine 1 tablet weekly, atovaquine plus proguanil 1 tablet daily. Okay, this is what is the strength here: 250 atovaquine plus 100 milligrams of proguanil, and proguanil plus chloroquine 2 tablets daily and 2 tablets weekly. So chloroquine will be 300 milligram, that is 150 milligram each tablet. So you will give 2 tablets. So when proguanil is combined with chloroquine, the dose is 2 tablet. Okay. When atovaquine and proguanil is combined, there is 1 tablet of atovaquine. Okay. This is what is the dose. Okay. And this will be used in a chloroquine resistant and mefloquine not tolerated cases. Okay. So in those cases only atovaquine plus proguanil. Otherwise, mefloquine is the drug of choice and 1 tablet weekly. And this is useful in chloroquine resistant areas. Okay. So folic acid supplementation 5 milligram per day is required if proguanil is used during pregnancy or when planning the pregnancy. So always, if you have any option with this 5 milligram supplementation along with proguanil, and the proguanil will be mainly in a chloroquine resistant and mefloquine is not tolerated. Okay, in those cases only you go for proponent. So that finishes the this guideline. Thank you.